Hello, it's Eric from Strong Medicine, and today I'm discussing an approach to vertigo. The first step is to confirm that what a patient is describing to you is in fact vertigo. English speaking patients rarely use the actual word vertigo and instead will use the word dizziness. Unfortunately, dizziness is nonspecific. A patient reporting this symptom might mean vertigo, or they might mean something called presyncope, or something sometimes called disequilibrium. Let's discuss the difference between those three. I'll start with the primary symptom of interest for this video, vertigo. Vertigo is the illusion of motion while a person is stationary. Most, but not all patients describe a spinning sensation. If you've ever played the game Dizzy Bat, the sensation it generates is vertigo. Vertigo can last as briefly as a few seconds, or it can persist for weeks. The most frequently associated symptom is nausea, and the general mechanism by which vertigo occurs is a disruption of vestibular pathways, which can happen in the inner ear, along the course of cranial nerve 8, within the vestibular nuclei in the brainstem, or within the cerebellum. The next symptom that is frequently referred to by patients as dizziness is lightheadedness, also known as presyncope. This is the sensation of transiently slowed consciousness or feeling faint. It can progress to a brief loss of consciousness, known as syncope. When lightheadedness occurs, it is almost always brief, lasting seconds to no more than a few minutes. It can be associated with a feeling of warmth throughout the entire body, and visual changes such as blurring or graying out of the vision in both eyes. The general mechanism of lightheadedness is a transient reduction of cerebral perfusion. Last and least understood is disequilibrium. This is difficulty maintaining balance. It can last a few seconds or persist for weeks. It's usually associated with frequent falls without a loss of consciousness, which would otherwise suggest syncope. Affected patients may become fearful of walking. The general mechanism is usually sensory deficits in multiple modalities. While it's not always as unambiguous as this chart might suggest, a clinician can usually place a patient's dizziness into one of these three categories. Now, focusing just on vertigo, the diagnostic framework is best divided into peripheral versus central etiologies. As a general rule, the peripheral etiologies are relatively common compared to the central ones. Starting with the peripheral causes, causes within the labyrinth include benign paroxysmal positional vertigo, usually abbreviated BPPV. In BPPV, the crystals, known as otoliths, become dislodged and float freely in one of these semicircular canals partially responsible for balance. When these crystals move within the canals in response to changes in position, they lead to excessive activation of the canal's sensory cells. So changing position, which should only be a transient sensation during the actual movement, persists for seconds to as long as a few minutes. BPPV classically causes episodes of brief vertigo triggered by moving from a lying to sitting position or standing position, or when turning one's head while supine. A less common cause of episodic vertigo, due to a problem in the inner ear, is Meniere's disease. This is believed to be caused by, or at least is associated with, an increased volume of a fluid called endolymph, which is responsible for transmitting sound waves to receptor cells in the cochlea and for detecting angular acceleration within the semicircular canals. Symptoms of Meniere's disease include discrete episodes of vertigo lasting between 20 minutes and a day, associated with progressive hearing loss and with ringing in the ears, which can either be episodic or can be constant. A perilymphatic fistula is a tear in the membrane that separates the inner and middle ear, a rare complication of head trauma or barotrauma, which causes episodic vertigo and or hearing loss that's triggered by anything associated with abrupt changes in pressure within the middle ear. This can include sneezing, coughing, straining, or even loud noises. And last in this category is the rare autoimmune disease Cogan syndrome, which presents with a combination of Meniere's-like attacks of transient vertigo and hearing loss, along with interstitial keratitis, and sometimes various forms of systemic vasculitis. Moving to the main nerves that are involved in vestibular sensory function, they include cranial nerve 8, also known as the vestibulocochlear nerve, which has two branches, one of which is the vestibular nerve, which receives signals from the vestibular hair cells of the inner ear that are directly responsible for sensing position and movement. The most common etiology in this category is called vestibular neuritis. This is a benign self-limited disorder thought to be most likely due to viral or post-viral inflammation of one or both nerves, but a viral mechanism has not been definitively established. Some clinicians use the term vestibular neuritis interchangeably with the term labyrinthitis, while others reserve the latter term for only those patients who also experience temporary hearing abnormalities along with a vertigo. An acoustic neuroma, also known as a vestibular schwannoma, is a benign Schwann cell-derived tumor of the vestibular nerve. As a consequence of the slow growth of the tumor, unilateral hearing loss is a more common symptom than vertigo, since central vestibular centers can gradually adapt to the lack of unilateral vestibular input. Sometimes acoustic neuromas are classified as an etiology of central vertigo, presumably because their presentation is more similar to central etiologies. But as it affects a part of the peripheral nervous system, to me, it feels more appropriately categorized here. Ramsay-Hunt syndrome, also known as herpes zoster oticus, is essentially shingles affecting the ear, manifesting as unilateral facial paralysis, ear pain, vesicles within the auditory canal and on the auricle, hearing loss, and of course vertigo. The final peripheral cause of vertigo I'll mention is called vestibular paroxysmia, which is a rare, poorly understood chronic condition manifesting as very brief attacks of vertigo occurring several times a day, sometimes with auditory symptoms during attacks. Moving to the less common central causes of vertigo, they can be separated into vascular versus non-vascular etiologies. Among vascular causes, the most notable is a transient ischemic attack or stroke of the posterior circulation. Two specific entities here include lateral medullary syndrome, also known as Wallenberg syndrome, and infarcts or hemorrhage of the cerebellum. Both of these would almost always be associated with significant other neurological deficits. Among non-vascular central causes are migraines, which are called vestibular migraines when vertigo is a prominent symptom, and multiple sclerosis. The most common cause of vertigo is BPPV, and those conditions which specifically cause episodic vertigo include BPPV, Meniere's disease, perilymphatic fistula, Cogan syndrome, vestibular paroxysmia, and vestibular migraines. The sensation of vertigo usually requires an asymmetry between right and left vestibular inputs and processing, so any condition or exposure that results in symmetric dysfunction, such as aminoglycoside toxicity or alcohol intoxication, tends to cause vestibular dysfunction, such as impaired balance, but without the specific symptom of vertigo. One nice thing about the diagnostic workup for vertigo is that even more so than with the other symptoms I've discussed in this video series, the diagnosis can usually be made from symptoms and exam alone. Starting with the history, the first step is to have the patient describe the nature of the sensory disturbance that they are experiencing. That is, you want to confirm that the patient is reporting vertigo and not lightheadedness, disequilibrium, or other neurologic symptom. Next, consider the time course. How long has it been present, and is it episodic or continuous? Is there a specific trigger for the vertigo, most commonly a change in position? Realize that all vertigo worsens with head movement. It's only diagnostically helpful if the vertigo is absent at rest and is triggered by movement, which specifically suggests BPPV. Other triggers to ask about include onset after head trauma, as well as triggering by coughing, weightlifting, or straining with bowel movements, all of which suggest a perilymphatic fistula. There are a number of associated symptoms to ask about. Concurrent hearing loss and tinnitus, or ringing in the ears, suggest Meniere's disease. headache and photophobia suggest migraines. Concurrent ocular symptoms beyond photophobia suggest Cogan's syndrome. Other concurrent or prior neurologic symptoms suggest multiple sclerosis or a posterior circulation stroke. If the patient has a deficit imbalance that is more prominent than vertigo, it suggests bilateral and symmetric vestibular damage, which is classic for immunoglycoside toxicity, but can also be seen with Meniere's disease. There are several relatively unique symptoms that can be experienced by patients presenting with vertigo. The first is called a tilt illusion, which is the sensation that everything in the world is tilted with respect to gravity. Drop attacks are sudden losses of postural tone without a loss of consciousness. And oscillopsia is a sensation of to and fro movement of the environment, which may be either sudden and jerky or smooth and regular. When smooth, it's associated with a physical finding called pendular nystagmus. This symptom is typically more prominent when the patient is walking and the head is in motion. Questions about past medical history should focus on atherosclerotic risk factors and also ask about past migraines. The focused exam for a patient presenting with vertigo should include an ear exam and a thorough neuro exam. There is a specific combination of relevant exam findings that have been bundled together as the HINTS exam, HINTS, which stands for head impulse, nystagmus, and test of skew. Because the HINTS exam has been reported to have very high positive and negative predictive values for distinguishing central from peripheral etiologies, it is a particularly important part of the vertigo evaluation. For the head impulse test, ask the patient to look straight ahead at your nose and keep their gaze on it while you passively turn their head to the side. The most important phase of the movement should be relatively quick, but to make sure you don't injure the patient, a good technique is to slowly turn the head about 20 degrees to one side and then quickly return it to the midline. It's also important to mix up the speeds and direction of the movements a little to prevent the patient from unconsciously anticipating the movement. A normal response is for the patient's gaze to remain on target, while an abnormal response is for the person's gaze to initially move, followed by a rapid corrective eye movement back to the target. This should be repeated in both directions. In the case of vertigo, an abnormal test is actually reassuring, since it suggests a probable peripheral cause of vertigo, whereas a bilaterally normal response is more consistent with a central cause. To test for nystagmus, ask the patient to look straight ahead and look for any movement of either eye. Then ask the patient to look to the extreme in one direction and hold for a few moments, and then repeat in the other direction. A reassuring finding is either no nystagmus at all or only unidirectional horizontal nystagmus. Unidirectional does not mean unilateral, but rather that the fast component of nystagmus is always in the same horizontal direction. Any other type of nystagmus, for example bidirectional nystagmus, is strongly suggestive of a central etiology. Last is the test of skew. For this, ask the patient to look straight ahead at your nose, and then cover one eye for a few seconds, and then rapidly move to cover the other eye instead, and go back and forth, and look to see if there's any movement of the uncovered eye. Adjustment of the eye as it is uncovered implies vertical misalignment of the two eyes and is considered a positive test. To summarize, the HINTS exam indicates a likely central etiology if any of the following are present. The patient has a normal head impulse test, bidirectional or other unusual form of nystagmus, or an abnormal test of skew. The last part of a focused physical exam for vertigo is the Dix-Hallpike maneuver, which is specifically a test for BPPV. For this, the patient needs to be sitting lengthwise on an exam table in which the examiner is able to stand at the head. Then, with the patient's arms folded, as relaxed as possible, and head turned 45 degrees towards the examiner helps the patient to smoothly but quickly lower the head straight back and slightly over the edge of the table. The evocation of nystagmus with this maneuver is considered to be a positive test and is indicative of BPPV. It should be repeated on both sides. As a general rule, the Hintz exam is most appropriately performed on a patient with hours or days of continuous vertigo, whereas the Dix-Hallpike is most appropriately performed on a patient with brief, recurrent episodes of vertigo. It would be unusual for both the Hintz and the Dix-Hallpike to be indicated in the same patient. Most cases of vertigo can be successfully diagnosed from the history and exam alone, and routine blood tests are rarely, if ever, helpful. However, there are a couple of additional tests occasionally indicated. Specifically, audiometry, or a formal hearing assessment if Meniere's disease is suspected, and a brain MRI plus or minus an MRA if a central cause cannot be ruled out from the history and exam alone. Let's now look at an overall algorithm for evaluating vertigo that puts all of this together. First, we start with a patient reporting dizziness, and we must discern between the three possible syndromes. Is it presyncope, in which the patient clarifies dizziness by describing a feeling of faintness or like they're going to pass out? The symptom of presyncope may be triggered by upright posture, certain situations like urination, a coughing fit, or emotional shock, or it can be spontaneous, and it can be associated with loss of consciousness. Or is the patient describing disequilibrium, which the patient feels unable to stay balanced when standing or walking, symptoms are worse with walking, and it's associated with frequent falls but without faintness or loss of consciousness? Or is the patient's dizziness vertigo, in which the patient feels like the room is spinning or that they themselves are in motion? Vertigo is worse with head movement and is often associated with nausea. Focusing just on the further workup of vertigo, there are 4 common clinical presentations. The patient could have recurrent episodes, lasting seconds to a few minutes, which are not only worsened by movement, but also triggered by movement. This is the typical presentation for BPPV, in which case the next step is the Dix-Hallpike maneuver. An abnormal Dix-Hallpike combined with the classic presentation is sufficient to confirm BPPV. However, this maneuver only tests for otoliths in the posterior canals, which is the most common. But if there are free otoliths in the anterior or horizontal canals, the maneuver may be normal. There are some additional tests for these uncommon forms of BPPV that are beyond the scope of this particular video. In contrast to the extremely brief episodes of vertigo and BPPV, the recurrent episodes can last many minutes to hours. In this case, the patient probably has vestibular migraines or Meniere's disease. To distinguish between them, check audiometry. If the patient has either episodic symptomatic hearing loss, episodic tinnitus, or has low-frequency hearing loss as picked up on audiometry, which could be subclinical or asymptomatic, the patient probably has Meniere's disease. On the other hand, if the patient has neither auditory symptoms nor abnormalities on audiometry, they likely have vestibular migraines. If the patient's vertigo has been a continuous single episode and they have an abnormal Hintz exam, they probably have a central etiology, in which case a brain MRI plus or minus MRA is indicated. The urgency of neuroimaging is dependent upon the acuity of symptom onset. If a diagnosis is made, you should further work it up as indicated. If the MR is unremarkable, you should consider rare causes or potentially a false positive Hintz exam in a patient with vestibular neuritis. And last, if the patient's presentation has been a single continuous episode lasting days or less, with or without an associated viral syndrome, they probably have vestibular neuritis. For most patients, the appropriate next step is symptomatic management and reassessment in 1 to 2 weeks. If symptoms resolve, no further workup is indicated unless the vertigo recurs. If the symptoms persist, then neuroimaging is usually warranted. Now, there's one big caveat to this algorithm. While the Hintz exam is believed to be very accurate at distinguishing central versus peripheral causes of vertigo, it's not perfect and is examiner dependent. This, combined with the fact that you really don't want to miss a posterior circulation stroke, means that if you are considering vestibular neuritis as the most likely diagnosis, but your patient is older, has stroke risk factors, and certainly if there are other neuroscience and symptoms present, consider neuroimaging without first waiting 1 to 2 weeks. The key takeaway points of this video. It's important to distinguish vertigo from lightheadedness and disequilibrium, all three of which may be referred to as dizziness by the patient. The most common etiology of vertigo is benign paroxysmal positional vertigo, a diagnosis of which can usually be confirmed by the Dix-Hallpike maneuver. The diagnosis of a patient with vertigo is predominantly based on the history and physical exam. And last, the HINTS exam, which stands for Head Impulse, Nystagmus, and Test of Skew, is an important component of the evaluation of vertigo. An abnormal HINTS exam should warrant an MRI plus or minus an MRA to look for central etiologies such as a posterior circulation stroke or multiple sclerosis.